Hello, everyone, and welcome to Hospice and Palliative Care for People with ALS with Dr. Martha Twaddle. We will get started in just a few minutes. We're waiting for others to gather. Thank you. Welcome to Hospice and Palliative Care for People with ALS. I would like to acknowledge all of our veterans on this Veterans Day. We know that veterans are twice as likely to be diagnosed with ALS, and we certainly appreciate you and we salute you. I want to go over some housekeeping items before we begin our webinar today. Please know that you're muted, you're not on camera, and so you can relax and enjoy the presentation. The presentation will last for about an hour today, and you will notice in our chat box to the right of the screen that you can enter questions. We'll have a Q&A session after the presentation. Some of you are aware that we had issues with our question and answer session the last couple times, but we believe that we fixed that problem, so we should have no issue retrieving your question. Lastly, this program is being recorded and will be available to view on our website, and I'd say the next week or two. So let's get started. I'm Nicole Sammartino, Community Education Manager for the Les Turner ALS Foundation. Thank you for joining us today for our ALS Learning Series with Dr. Martha Twaddle. Although we know that ALS is currently an incurable progressive neurodegenerative disease, it remains difficult for patients, families, and healthcare professionals to have discussions about the progression of this serious illness and to plan for end of life. This is most often due to the overarching apprehension that clinicians, families, and patients have regarding how to talk about it, what to say, and most importantly, when to say it. This webinar will cover how to talk about end of life, what to say, and when to say it. We'll discuss the differences between palliative care and hospice care, as well as their benefits, services offered, and when to seek out this care. Also, what you need to know before signing up for hospice services. Before I formally introduce you to Dr. Twaddle, I'd like to tell you a little bit about the foundation. The ALS webinar series is made possible because of the Gilbert and Jacqueline Fern Foundation and our industry partners. Biogen will be sponsoring today's webinar for us today. Thank you. We are leaders in comprehensive personalized ALS care and research, and we realize that people with ALS may feel overwhelmed and unsure of what questions to ask and what to do next. The Les Turner Foundation, ALS Foundation, exists to care for those affected by the disease, guide them to answers, support them and their loved ones, and provide hope through scientific research. Our support services team is comprised of knowledgeable and compassionate nurses and social workers with many years of experience guiding people and their families affected by ALS. We offer a variety of services, including care visits by ALS support services coordinators, support group meetings, educational meetings, materials, and so much more. At the Lois and Salya ALS Clinic at the Les Turner ALS Center, we offer access to enrollment in clinical trials and dedicated clinical trial coordinators. We are Chicagoland's first and largest multidisciplinary ALS clinic with the highest number of neurologists and dedicated pulmonologists. And we also offer multidisciplinary care that brings together an experienced team of neuromuscular specialists in one clinic to provide comprehensive support for you and your family. It is now my pleasure to introduce you to Dr. Martha Twaddle. She is with a combined over 30 years of experience in the care of seriously ill people and their families in a variety of areas of service. She currently serves as the WAD Family Medical Director for Palliative Medicine and Supportive Care at Northwestern Medicine. Dr. Twaddle's unique talents and contributions to the field of palliative medicine have helped increase the understanding of and access to the continuum of care regionally and nationally. She has been the recipient of countless awards and recognized for countless achievements, including the AAHPM Lifetime Achievement Award conferred in March 2019. After graduating summa cum laude from Purdue University, Dr. Twaddle received her medical degree from the Indiana University School of Medicine in Indianapolis and completed her residency in internal medicine through Northwestern University McGaw School of Medicine, where she was chief resident. She currently serves as a clinical professor of medicine for Northwestern University Feinberg School of Medicine and is board certified in internal medicine and hospice and palliative care. It is my pleasure to introduce you to Dr. Martha Twaddle. Welcome, Dr. Martha Twaddle. How are you?
Thank you so much for this incredible opportunity to be with you today. I'm super grateful. I'm up in the wilds of Wisconsin, and I'm really glad to be here with you today. So let me get my screen launched. I think there's a few people for some reason who are not on mute. Looks like the screen launch didn't.
Ours didn't launch.
Let me just move this. Hold on one second. Are you able to see my screen?
Not yet.
Can you do that again? Do the launch thing again? It worked just fine just a minute ago.
Let's see.
Let's see. How about now?
Not, there you go. I see your screen, Dr. Twaddle.
Can you see my slides?
Yep.
Okay, good. Okay. So again, great to be with you today. Very, very honored to be able to provide this talk to you all. And
What happened now? I hear us talking. Well, did they cut themselves off? Hello?
Hello?
We're having some difficulty with technology. Please be patient. We'll be with you as soon as possible.
I don't know if I should leave this on or off.
I don't know why we can hear. Dr. Twaddle, can you hear us? She may have been, there she is, she's back. Dr. Twaddle?
I lost connection. Can you hear me okay?
Yep, I can hear you.
And can
We
you
can
see my slides?
Yep, just start again and I will let you know. I see your slides.
Perfect. Okay.
Perfect, okay.
So I'm so sorry for that, but that's beyond our control. It teaches us how many things are out of our control. The first thing I want to do is I just really want to share a moment to reflect on two great, amazing people who inspire me and taught me a great deal about this illness in recent months. And that would be my colleague, Dr. Randy Curtis, who was diagnosed with ALS last spring and has really taught all of us in the field what it means to live with this illness, as well as a recent patient of mine, Kathy, and that's all I'll share, who her courage and wisdom and forthrightness through this process has again reinforced to me the importance of the information I'm going to share with you. This slide is not a picture of my needlework. This is not Bargello stitch, but this is actually what's called a mortality map. And it looks at the incidence of illnesses and why people die in the United States, and for men and women on the far left, and then across the grid, different ages. And really, I show this slide because it presents the visual that what we recognize when we look at this is 100% of people die. I know that sounds silly to say, but I think many of us live as though we might get a by and we're not going to have to confront this part of our life. We tend to be really good about preparing for childbirth and weddings and graduations, and some of us think a bit about wills and such like that, but for the most part, the vast majority of people, more than 80% of people, do not prepare for being seriously ill or thinking about what would happen if they have a diagnosis. And when confronted with a serious diagnosis, we recognize that our timing and our sense of control over this is going to be very different. And being able to prepare and communicate what's most important to us becomes vitally important for ourselves and for our family. So what I'm going to talk about in this time together, and we'll have, I hope, ample time for questions, is what is palliative care? What is it that I do? And what is hospice care? And when do I think about them? What's the timing for accessing the support that those different support services might provide for me? A question I would leave for you that you don't need to answer in this hour, but to think about is, where do I want to be at the end of my life, and who do I want to have with me? Even identifying that can be very, very helpful. And why this is important, I will say first and foremost, is it is a gift we give those who love us. It is a relief to know that when we're losing someone we love, we know what it is they want. We know where they want to be. We know who should be with them. We know what type of care would be meaningful and helpful to them. So planning is a gift we give the people that we love. A couple of resources, kind of easy and fun to read. One is this book by Roz Best, which is really comes from the perspective of kids with aging parents. That's the Can't We Talk About Something More Pleasant? It's got a lot of good nuggets of information in it, and it's silly in the way it's formatted because it's a comic strip. But actually, the book I refer to a lot is written by a very dear friend of mine, BJ Miller. He's got some great YouTubes, by the way, and TED Talks. And BJ wrote this book. It came out, I think, the year before last with Shoshana Berger. And it is very practical. It is like that book, What to Expect When You're Expecting, in terms of what are some of the things that you should do and think about as you prepare for the end of your life. And just so you know, I'm going to give a copy of these slides to Nicole. So if you all want to get a PDF copy, you can just let us know and we'll get it to you. You know, as we face serious illness and we face end of life, we think about how important it would be to have a healthcare professional that we trust, that knows us, that we feel safe with. And I'm dating myself to put this picture up here, but because a lot of young docs have no idea who Marcus Welby was, you know, like the quintessential physician who knew his patients, did house calls, and solved mysteries all at the same time. That type of world of healthcare is harder and harder to find. And ever since really post-World War II, the pace and change of healthcare with its focus on cure and intervention has grown exponentially. And the culture of healthcare has become very much one of the warrior culture of fighting disease and smiting illness. And success, for the way most physicians and healthcare professionals think, is cure and restoration. And yet for many people, if you think about it, most people, that isn't an outcome that anyone will see. All of us are going to die, and we need a healthcare system that isn't just about diagnosis and treatment, trying to get rid of a disease that we can't get rid of. And there may be a point where the prolongation of life is a source of suffering, and we need to be released. So the biomedical model of care is what those of us who are in the field of palliative medicine responded to and said, it's not enough. It's not the best possible model for really caring for people and their families who face serious illness. It leads to isolation and can lead to suffering as people become objectified as far as, hold on a second, I look like I'm losing power. I'm sorry, you guys. It's been one of those days. Become objectified as far as being a diagnosis versus being a person, and having people focus on you to care for you as a person. Right, give me 2 seconds. I'm plugging in my computer and I'll be good. Oh, power is a wonderful thing. Okay. So even in 1982, Dr. Eric Cassell published this in the New England Journal of Medicine, and I remind myself of this message many, many times, that our goal as clinicians is to relieve suffering first and foremost, as well as to attempt to cure disease when possible. But those are not exclusive of one another. We really need to understand what it constitutes suffering for an individual. How do they define suffering, as well as how do they define quality of life? It's not how we define it, it's how the person with the illness defines it. And we also have to be thinking about their caregiver and the impact that the illness has on those who love and care for them. So back in post-World War II and into the 60s, a remarkable human being named Cicely Saunders, Dr. Cicely Saunders, helped to intensify, strengthen, and grow the modern hospice movement. Saunders started her career as a nurse. She then became a social worker during the war, and then went back to become a physician. And if she had spiritual care training, she would have been an interdisciplinary team in and of herself. Saunders was the first to apply a scientific model and really an exploration of the needs and response to therapies of the dying versus those who had curable illnesses. And her work strengthened the delivery of the care for those at the end of life very profoundly. So the goals of hospice care are first and foremost to relieve suffering, promote quality of life as defined by that person who is ill, prepare for death that is expected, not to deny it, to see that it's coming, and to be prepared to the extent that the person wishes to be. People who go into hospice care are no longer receiving disease-directed treatments. So treatments that are focused at trying to prolong life or to treat the disease are usually not effective at the end of life. And so those treatments are set aside to focus on symptom management, full palliation of any symptoms. And the interesting thing is that people who make that change often live longer than they might have if they continue just disease-directed treatments. That we see in oncology tremendously and need to study more in other diseases as well. The unit of care, as is often said, is not just the patient, but it's the person and all that is important to them. Their family, which might be biological, might be chosen, are part of the care plan and part of the team in providing the care. And hospice is accessed when people are reaching the final months of life. So the goal is to be there obviously before, as soon as possible, to establish relationship, to increase support. And certainly when symptoms are increasing or family needs for support and guidance are increasing, having a team come into the home and support a person and their family is beyond words. I'm going through it right now with my mother. So this is very, very clear to me as to the benefits of this kind of care, how it eases the stress of what it is that we're walking through. Now, interestingly, Saunders' original model was a facility. It was a hospital. Hospice was a place that you went, and still is in many places in the UK and Europe. But when it came to the United States, it changed very remarkably. And this little lady, she was Dean of Nursing at Yale, New Haven, worked with Saunders in the 1970s. About 1975 was the Connecticut Hospice Project. And Dean Wald helped to create a plan for hospice care in the United States, but it changed greatly from what Saunders had originally created. It became a home care model, quickly adapted to be like the equivalent of home health for seriously ill people. And that model was so enthusiastically accepted by Americans and leaders in healthcare. It made so much sense for our culture. As opposed to a facility, it was people coming to the ill and the dying in their own homes, whatever they considered their home. So this is a group of folks who helped launch the demonstration project and then the bill that became law for the Medicare hospice benefit. This is in 1986, and many of these folks still work in the field, are friends of mine. It's pretty remarkable to see that photo. And it's important to realize, hospice is a philosophy of care. It's a team-based, whole-person philosophy of care and a model of care. However, it is also an insurance benefit, and it is defined and it is defined and regulated through federal law. So it's not just any insurance benefit. Now, most commercial insurance and Medicaid, state-based insurance mimic the Medicare hospice benefit, not completely. So folks help us figure out, okay, what does my hospice benefit have if I'm not in Medicare? There is, if you want to read the Federal Register, there's interesting information on what the benefit covers. And basically, it is 2 90-day periods are the first 2 benefit periods, and unlimited 60-day periods thereafter if you remain eligible to use this benefit. The other thing is that people can go in and out of hospice care. That folks sometimes don't realize that you can opt out of hospice care and come back into hospice care depending on eligibility And also if goals change or something else happens, you can sign in and out. So it is a benefit, insurance benefit that you elect and that you agree to use. And it's overseen by a Medicare hospice program that delivers the care. If you're going to use your insurance benefit, then the program that you access needs to be certified to be able to provide it to you. So I started my career as a general primary care physician in internal medicine. And I worked as a hospice volunteer and volunteer medical director in the late 80s as this benefit was becoming actualized. And I would see patients for hospice care. And very quickly, I thought to myself, why is it that we wait till people are dying to talk about what's most important? What is quality of life? What are the goals of care? Shouldn't this be happening when we receive the serious news of a diagnosis? Why are we waiting? Found it deeply, deeply disturbing. And I thought, I'm not the only person who has this question. There's got to be great thought leaders who have also struggled with this and perhaps even have found solutions. And there are. And there were. This gentleman, Dr. Balfour Mount, a wonderful mentor and friend, was the head of, I don't know if he's the head, but he became the head of palliative medicine. He was a urologic surgeon at McGill University in Montreal. He studied oncology surgery at Memorial Sloan Kettering, and then went, as he liked to say, went across the pond to study with Saunders in England, and came back to Montreal with this idea of how to integrate whole person team-based care that focused body, mind, and spirit to help people with serious illness from the time of diagnosis. And he realized he could not use the term hospice, that hospice had all sorts of connotations. In Montreal, it means a halfway house. So it really wasn't going to work as a term. So he created the term palliative care, and palliative medicine being the medical model, the medical training that folks receive in order to, the clinicians, to deliver this care. And he started the scientific work, the research work that continues to this day to demonstrate that this type of care is not only helpful, but it really gives life and helps support meaning for those who are seriously ill. So palliative care is, got two little nuances to it. Palliative medicine is what I'm trained in, a specialized form of medicine. It's a medical subspecialty in the United States. I could tell you all that story too, but we don't have time today. Started, interestingly, at Northwestern. And palliative care is when the team is integrated into the assessment. So when I see a patient by myself and provide input around managing symptoms, et cetera, that's palliative medicine. But when I integrate with social workers and spiritual care and therapists, then it becomes a team, and then the person and their family in the middle to support the plan of care. Palliative care, by definition, requires a team. There has to be a team present to deliver this care. It requires it in so many ways. And palliative care is for any serious diagnosis, particularly those that are progressive and complex with an increased risk of mortality. It is integrated into the curative and treatment phase of illness. So ideally, at the time of diagnosis, that's when palliative care assessments would begin and follow that person throughout the entire trajectory of their illness. So it's not driven by their prognosis, it's driven by the need for team-based, whole person, body, mind, and spirit care. So at Northwestern, we call it palliative medicine and supportive care to emphasize that it is a subspecialty like cardiology and urology, but it also is a team supportive care. So again, it differs from hospice in that hospice is a form of palliative care supported by specific insurance benefits for which people are eligible when they are in the final months of life. And the definition of terminal illness in most regulatory language is a prognosis of 6 months or less if the illness follows its usual course. That doesn't mean that every hospice patient lives 6 months. My mother's lived 14 in hospice. It depends on the illness and it depends on the trajectory, but the intention and the eligibility are carefully reassessed by the hospice team. So all that is hospice is palliative care, but all that is palliative care is not hospice. And that palliative care team really is very dynamic in terms of how it integrates with the treatment team throughout the trajectory. And palliative care may play a very minimal role at some times in an illness and then intensify, of course, as people get closer towards the end of life. And that transition then to hospice is simply an integration of more team members, more folks to help, and is not quite so jarring or abrupt. It's a natural progression of increasing support. And then also the support for those who love us after we're gone is really critical. So I like to think of modern medicine, I was a swimmer, as swim lanes and laps, and everybody's in their lane, they do their job. There's a little bit of communication, but sure not much. And palliative care is Esther Williams. Again, I'm dating myself. But the patient and family in the center and the team collaborating, communicating, coordinating, cooperating all around them. Lots of C words to help support and buoy them up in the as they live with serious illness. So a key part of what palliative care teams help with is for us to establish what are called advanced directives. You've probably heard about this and people have asked you about this. And I think it's important to take some time just to, what are advanced directives and why? The most important thing is advanced directives start a conversation with those who care about us, professionals and family, so that we can verbalize, we can give voice to those things that are most important to us as we become too ill to speak for ourselves. So people have this right that we need to know, and the more often we have these conversations and in little bits and pieces to establish with those who love us and who will care for us, so they know what to do when we are too ill to direct. There are lots of different advanced directives, and I'm going to go through just a few here, emphasizing ones that you absolutely must have. Now, the very first advanced directive that was created, and I don't remember when, was what's called a living will. And a living will is a declaration that people would create that talks about what they don't want done. Usually, it really emphasizes, don't do this to me, don't do that to me when I'm too ill. And it is activated, a living will is activated to be an advice or a guideline when the person is very, very ill or terminally ill. The problem is, and I'll explain what this means as we go forward, it is not an actionable document. So, for example, if you had a living will and a power of attorney, which we'll talk about in a minute, and you called 911 and your living will said, I do not want to be resuscitated in the event of my death. I do not wish to be on a ventilator. And that's in your living will. And your power of attorney is even present or accessible. The paramedics cannot pivot or adapt their care plan in light of your living will. It's not an actionable document. So kind of keep that in your mind. We're going to find together, I'm going to show you which document is actionable because we need that. One of my favorites, honestly, as far as a directive and kind of better than a living will, is what's called 5 wishes. And the picture of Mother Teresa is because the gentleman who created 5 wishes was Jim Toomey, who was Mother Teresa's lawyer, really great guy. And that's another story of why Mother Teresa needed a lawyer. But he worked with her, and throughout his adult life, he spent time with her. And this document talks about what you don't want done. It also talks about what you do want done, like what do you find comforting? So for example, my 5 wishes says things like, please don't turn on the TV. If I'm so weak and I can't turn it off, please don't turn it on. No high-pitched sopranos with vibrato. It makes my hair stand on end. Wash my mouth out with dark beer or red wine if I can't swallow anymore. Those are flavors I love. And these, as silly as that might sound, writing those things and sharing those things with my family so they know truly what it is that brings me comfort and what causes me distress. They didn't know that part about sopranos. The 5 wishes document also includes a form that helps you identify who you want for your healthcare power of attorney, which is probably the most important thing that any of us can establish. So a healthcare power of attorney is a person that we select who can channel us, who can speak for us, who can be our voice, who can be our champion. They may not totally agree with some of the things that we're saying, but they can act on them and they can be our true advocate. They wouldn't be just too distressed to be in this role. It wouldn't upset them too much. And that's why some people don't choose their spouse or their partner. Sometimes they choose another person because that person can do this for them without the repercussions they worry that their spouse or partner would have. And you can have a first designee and set the second and third, but it is critically important to do this. In fact, the law is that anyone over the age of 18 must have a healthcare power of attorney. These people speak to healthcare professionals on our behalf. They give permission for tests, they give consent. And when treatments are no longer helpful, they're the folks who say, stop that infusion, or please withdraw that ventilator, that's not what she wants. Give permission for donation of organs and what to do with our remains, whether we want to be buried, whether we want to be cremated. These are the folks who are empowered to sign the forms on our behalf, to channel us. Important to know, these are the 2 areas that I highlighted here are things that I find people do not understand about healthcare power of attorneys. You don't need a lawyer to do this. You can pull the form off the internet, the Illinois Power of Attorney form, and you can fill it out. You do not need to get it notarized or blessed by anyone. It is simply something you do. You want to give copies to critical folks in your life, your physicians, so they put it in the medical record. You want to carry it if you travel out of state. Most people don't realize that carrying certain documents when they're ill or have a diagnosis can be really, really important, particularly international travel. And you do not want to put it in your security box at the bank. Please don't do that, because some folks do, and then we can't get to it, and it's a nightmare. So it belongs somewhere very, very accessible, and that other people know where it is. It does need to be witnessed, and that has to be not a family member. So usually we grab our neighbor, sometimes the postman, or there can be some folks in your healthcare team who are allowed to witness it. So there is a hierarchy of decision makers that starts first with the person who is ill, and for as long as they can, we look to them to give directives and directions around what care is helpful, what they do and don't want, to provide consent for procedures, until which point their decision-making becomes impaired or is incapacitated. They simply can't provide input, weigh decisions, do burden-benefit discussions. They're not capable. And when that happens, when a person no longer has decision-making capacity, and interestingly, you can have dementia, but still have some aspects of decision-making capacity. So this is something determined by a physician. It's a little protocol that we go through to help us establish capacity. We either involve the power of attorney, or the power of attorney is the person who needs then to make decisions when we're incapacitated. The nightmare begins if we don't have a power of attorney for healthcare. Then it flips into surrogacy. And this list below here is the surrogacy hierarchy for Illinois. It may vary slightly in other states. What we look for is if the patient is incapacitated and there is no healthcare power of attorney, Then we look for a guardian, and most people haven't had a guardian. That's appointed by a court. We look to their spouse or civil partner. Now, if that is a person they had not wanted to be their decision maker, I'm sorry, that's who's going to do it. And the third is adult children. So this is me going into a family meeting with the adult children. And no, it's not always like this, but I beseech you to establish a healthcare power of attorney if it is the kids that would make decisions on your behalf, because they must all agree under surrogacy law. And sometimes, I will tell you that end-of-life decision-making discussions and the challenges that confront families are what rupture family systems if we don't begin to plan and prepare and communicate long before. Because this is where all sorts of things come to air and can cause great division and heartache and additional suffering and division. So I behoove you, please, I beseech you. So I mentioned earlier an actionable document. So if you have strong directives about what you don't want done, so for example, let's say you do not wish a resuscitation attempt in light that you're found to have died. If they find that you have died, you say your directive is do not attempt to restore my life. Then that's called a do not resuscitate. And if you were at home, in order to actualize that directive, if your family called 911, you have to have what's called a PULSed form in your home. And typically what we have people do is put it in a plastic bag in the freezer, not on the front of the fridge, because it just feels funny to have it there. We put it in the freezer. And this allows paramedics to align the care support to be consistent with those directives that you have set forth. So let's say you said, I don't want to be hospitalized. If I am so sick and in such distress, I want you to stabilize me at home. I want you to get hospice in there. This is the form that allows medical professionals, particularly paramedics, to redirect care. Because when you call 911, you give consent for treatment. And if you don't have a PULSed, then you get the full protocol, irrespective of what your living will says. So anyone who is frail, anyone who has a terminal diagnosis, who has a diagnosis that likely will lead to death within a year or so and has strong feelings about what they want or don't want, needs this form in place. It has 3 parts. On the Illinois form, one is whether or not you would want CPR, and this CPR is done when people die. So CPR is the response when you are found without a pulse and unable to breathe on your own. Do you want them to try to reverse that state or not? That's one section. The next section, separate, is when you are still alive but in extreme distress. How much, or you are very fragile and needing medical attention, how much intensity of treatment do you wish to have? Do you want them to go full court press, do resuscitation efforts in the sense of ventilator and move to the ICU and support you with infusions? So this would be, and I misused that word, resuscitation. You can be full treatment and DNR, which a lot of people don't realize. So that means that when you die, you don't want people to attempt resuscitation and try to bring you back. But while life is present, you want everything done to support you. The vast majority of my patients choose what's called limited treatment, meaning they want supportive care, antibiotics, hospitalization if necessary, infusions of different meds, but they do not wish to be placed on a ventilator. They don't want intubation. And so they will indicate do not resuscitate and limited treatment. So I still want you to do something, don't just leave me there. And some people will say, I want comfort focused care, I want hospice, I don't want to be hospitalized, just make sure I'm comfortable. The part about artificial nutrition, it's funny that it's on the PULSE form. It really belongs somewhere else. That's put in place on the PULSE form primarily because of nursing homes. And you can indicate it there, but it's not where we go to look at or document decisions around artificial nutrition. The benefits of doing these advanced care planning is it helps to communicate and guide care that can ignite or be prompted into action without our control if we don't have these orders in place or forms in place. And these forms follow us across care settings. So copies of these, again, if we travel out of state, if we go see our cousins in Indiana, we want to have a copy of our PULSE, we have a copy of our healthcare power of attorney. Anyone over, just to reiterate, anyone who is 18 or older must please have a healthcare power of attorney designated, otherwise it goes to their parents and it goes through that surrogacy hierarchy. Anyone who has a serious diagnosis should start these conversations and ideally create a 5 wishes. And anyone who's seriously ill and the disease is progressive, could lead to death within months to years, should definitely consider a PULSE form. These aren't a one and done, they may evolve. People may change their minds or redirect, and it needs to be talked about often. And that's really the whole gist of this conversation with you today, or presentation, is we have to talk about this often. Don't ask what's the matter with me, ask what matters to me. And we need to find those folks, professionals and otherwise, who will help be our advocates and allow and create a safe space for us to have these conversations. Some of us worry that, oh my gosh, if we have these conversations, we do harm. We worry that, if we bring this up with our loved one, they're going to get depressed. We worry that if we bring this up with our family, they might cause them distress. Actually, this study published in the Journal of the American Medical Association found the actual opposite of that people who had end-of-life discussions were not worse off emotionally. They more often than not accepted their disease as being terminal and were able to give directives. 63% selected a do not attempt resuscitation order. The caregivers of folks who didn't have these conversations or who received aggressive care had a much higher risk of depression and regret, felt unprepared for death when it came, and had worse quality of life and self-reported health. So what this means is end-of-life discussions are associated with less aggressive medical care. Most of us opt to curtail the intensity, and also are associated with improved quality of life near death. And they also improve the bereavement outcomes for those who love us. So they're not associated with the patient getting depressed or the caregivers getting depressed. They actually are helpful because we address the elephant in the room. And I want to touch on a tender subject because this is very, very common in the patients I've been privileged to care for over these past nearly 33 years, 34 years, doing the work that I do. And that is that more often than not in neurologic diseases, and particularly in ALS, there many, many people think about, I just want this to be over. In my career, I have never had a patient say to me, oh, could you let me die slowly? Could you draw it out? No, no one wants to die slowly. And there are people who even in the process of the deterioration struggle with what is unfolding and feel so out of control. That grief and that voice needs a safe place to be heard. Because sometimes in the sharing of that alone and that connection and that companionship is really what's needed, because we keep secrets from each other and we're afraid to say it, and yet we suffer. So what I look at and what I talk to patients and families a lot about are there things that we are doing that tether you to life when that is not where you want to be. And we have to be sure that we allow a process to not linger and not take forever such that people suffer. And so this conversation in particular needs a safe place and needs caring ears and hearts and open honesty. So there is in our country physician aid in dying. This is a practice providing a competent patient. By that, the patient at the time that they use the prescription has to be considered having capacity, full capacity to make the decision. They receive a prescription and they have to be able to give it to themselves. Now, this is not exactly the same as we hear the term euthanasia. So active euthanasia is facilitating someone's death, and that is not legal in the United States in any way, shape, or form. It is legal in the Netherlands. We have what's called physician-assisted suicide or physician-assisted death, and this is where a physician provides the means but does not participate in the action. It is legal in California, Colorado, Oregon, Vermont, Washington State, and Washington, D.C., and kind of sort of in Montana. It's a really weird law. It is not legal in Illinois. Interestingly, the word euthanasia literally means an easy death. And there's two parts to euthanasia. There's the active euthanasia in Belgium, Luxembourg, and the Netherlands. But there's also something called passive euthanasia, which is legal and ethically acceptable in the US, and that is allowing a natural process to proceed without hindering it. It's allowing death to occur by natural means and not making it last too long, or perhaps even withdrawing some of the artificial supports of feeding fluids and ventilatory support that is causing people to physiologically live beyond where it's life that is meaningful. I won't belabor this, but these are the different states that have physician-assisted suicide. You have to be a resident, you have to be 18 years old, you have to give two oral requests and one written request within 15 days of receiving the prescription in order to use physician-assisted death, and you have to have a certified prognosis of less than 6 months. So basically you're hospice eligible, and then you elect this intervention. And you have to be able to give the prescription to yourself. Someone else cannot give it to you. Bottom line is, we need a place to be able to talk about these things with the people that we love. And that's where I find the palliative care team often very, very helpful, is shepherding and counseling and supporting and giving space to these conversations in a supportive, caring environment. They're not a one and done. We touch on these and sometimes we need a break. Sometimes we don't want to talk about this, it's not pleasant, but we need to engage with it. And again, the more we plan and prepare, the better those we love and those who care for us can plan and prepare, because we're never ready. We're never ready, but we can be more confident that we know what to do when we're faced with something that we don't necessarily want to have happen. So above all, what we want is that people are able to live with integrity until they die, that what matters to them through the treatment plans is supported, and that is ideally the most important patient-centered outcome. So what we've covered today, and then I'm going to open it to questions, is we've talked about the difference between palliative care and hospice. Palliative care ideally begins when we receive the news of a serious diagnosis. We start those assessments, we integrate palliative care teams. Their involvement will wax and wane throughout a trajectory. Longest I ever got to work with someone was 13 years. I was part of her care team, and that was just amazing. All of us must have a healthcare power of attorney. Please don't leave it unaddressed. It's a nightmare. Most of us should complete a 5 wishes, or at least use that as a tool to guide the discussions that we have with our healthcare power of attorney. This is what helps me. This is what I don't want. Many of us should be establishing a pulse, because we have clear directives around resuscitation that we want to make sure are going to be respected. And all of us absolutely need to have safe space such that we can talk about our fears and needs, have open discussions around our end of life, that trusting relationship with our healthcare team, which the Les Turner team does an incredible job. That is so vitally important. And it, like I said many times in this slide, it's all about team. So thank you for this time to be with you. Our motto at Palliative Care is to live well and land softly.
Wow. Thank you, Dr. Twaddle. I mean, you really created this beautiful space for us to acknowledge and normalize these conversations with the reassurance that we'll be better off for it. So thank you for that. Let me see what questions. I know we have a few questions already. Okay.
And I'm sorry that my computer failed to take into our question time.
Oh, we'll make sure we address these questions. No worries. This was, I mean, honestly, I think you could have gone on so much longer. There's so much good information here.
There's so much.
Let's see. Beautiful presentation, my friend. My question is, the way palliative care is practiced locally is not working well for all of our people with ALS. They are in need of more frequent visits and interventions. Okay, so that was a great comment, certainly. Do you have
and just to thank you for that, for making that comment, because we are woefully understaffed across the country with palliative care, because palliative care doesn't generate any income for healthcare centers who are fee for service. And it is really through philanthropy and support that we can build our teams. And I'm so grateful to my supporters who built my team. But we do need to also insist to our legislators, et cetera, that they need to get on board, because there's been a bill for the last 5 years that's gone round and round and round to better support palliative care in the United States.
Thank you for clarifying. Do you have a palliative care practitioner embedded into your ALS multidisciplinary clinic, and what does that look like? Rebecca, I don't know if you can answer that for us, considering that's a question for our clinic specifically. So I can get back to Rebecca on that.
Well, and the other thing that people should realize is that competencies of palliative care increasingly are part of professional training, certainly for doctors and also for nurse practitioners and nurses. And people who work with seriously ill patients may not be subspecialized in palliative care, but may also be highly competent in palliative care and may be able to easily access the full team that includes the specialists of palliative care. So this is not swim lanes. This is Esther Williams. You bring into your team the members that you need to bring into your team. And the Northwestern is amazing in terms of the number of palliative care resources that it has.
Yes, you're absolutely right. And thank you for answering that, because that is exactly how our clinic is, in that there are experts. They may not be considered a palliative care practitioner, but we are having those conversations. We are writing, those doctors are writing those orders to hospice. So Rebecca, I'll reach out to you to see if that answered your question in full, Rebecca. There's a comment here, medical aid in dying is also legal in New Jersey. Someone wanted to comment on that.
Good to know. Thank you. That's probably recent. Thank you. I'll add that to my slide.
And then again, I just wanted to reassure everyone that the recording will be made available on our website, I'd say in the next week or two. And Dr. Twaddle has been kind enough to allow me to share the slides with you. How do I find someone that provides palliative care in my area?
So there is something called Get Palliative Care Online. I think the best is to work through your health center to find out if your health center has palliative care resources, your health team. Certainly the good old internet, but it's nice to work through people who have relationships, because it's coordinated team care it's seamless. Sometimes, like you saw on that slide, the waxing and waning. We want to have a team that can integrate. There are a couple or more teams in the Chicago area that provide home-based palliative care that I collaborate with when it gets to a point where my patients can't get to see me in the clinic anymore. Then I will help integrate with a home-based team. I don't own them. They're not my employees or Northwestern employees, but we still collaborate and we add more people to the team. I don't go away. I'm on telehealth. They're seeing the patient in the home. So that the first person to start with would be the specialist who's overseeing your care or your primary care doc. And if necessary, go online to look at Get Palliative Care or to talk to us up at Lake Forest, and we can also give you directions.
Great. How do I suggest a caregiver approach? How do I suggest a caregiver to approach their loved ones who has not accepted the diagnosis? And then this person would love a copy of your slides. So yeah, that's a tough one. We know that denial is a mechanism.
So denial is a very, very effective coping mechanism, but sometimes it moves into a place of pathology. And I think the other thing that we are very aware of in my field is that grief isn't something that happens at death. Grief happens all along the road. Every time we get bad news, every time we see that we can't do what we used to do, we grieve it. And some of us, our ability to engage with that can be very, very limited. Now, I've had patients who don't want to talk about it, don't want to acknowledge it, but are still willing to access supportive care and have our involvement. And that's okay. We don't have to talk about it. We don't have to use the term hospice. It's okay. I just want to be sure you get the right care and that the care is meaningful and helps you feel safe. It doesn't have to have a name, and we don't have to have it be the topic of conversation. Other than consent, there are some patients who are very capable of making their own decisions will say, I want my healthcare power of attorney to make all my decisions. I don't want to talk about it. That's okay. That is ethically sound. You just have to have healthcare power of attorney to be able to do that for you. So again, denial is how we cope with just overwhelmingly sad news. And then we as loved ones have to figure out, okay, in light of your denial, may I still move forward with some of the things I think you need to care for you? Listen, we don't have to talk about it, but I need to be able to then care for you well, even if we never talk about it.
Very good. Dr. Twaddle, is palliative care covered under insurance? Because I know that hospice is covered under the Medicare benefit. Is palliative care?
Yes.
Great.
So palliative care is a bit more of a smorgasbord of different services that are brought forward, and insurance will cover those. Palliative care covers a palliative care consultation by a healthcare professional. It covers the nurse practitioners, the therapists, et cetera. Those, we figure out ways to support the delivery of care. It is not covered with a overarching benefit like hospice, which in truth, I have to say I'm glad, because that is limiting. Then you get all the regulations and all this stuff that they tell you can't have. So palliative care allows us to be more fluid, to find the right people on our team, to figure out ways to support them. And most of them can bill for the care they give. Some can't, and that's where philanthropy, et cetera, becomes tremendously important, is that we look to philanthropy to help us at least launch some of these non-reimbursable services.
Great. See, you have time for a few more questions?
Sure, I do.
Excellent. So someone wrote, so because of residency requirements, patients who do not live in those states where it is legal have no options for physician aid in dying services?
That's true. So in Illinois, it's not legal. But what I would emphasize is these conversations and making sure that interventions are not in place that prolong the dying process. Because more often than not, what happens is that people are on oxygen, people are continuing to get fluids, people are ventilated, and it is very, very difficult to die if you have interventions happening that are working against you. So having a conversation conversation about I do not want this to go on long. This is untenable to me. It is feasible to have sedation at certain phases. That is ethically sound, even in states that don't have the physician-assisted death. And certainly to review what it is that the person is receiving that can be very carefully, thoughtfully removed, and any symptoms that might be related to that managed so that person is allowed to die in a natural way. So, years ago, I took care of the guy who was the head of the Hemlock Society in Illinois. And I'll never forget him saying to me, he goes, if I knew that hospice could do what it did for me, I don't know if I'd feel as strongly about needing to truncate this process, because I've been able to live well for longer than I thought I would because of symptom control. And I don't feel like my death is going to be this strong. And it wasn't. He actually, when the end came, it was pretty rapid. And he and his wife really were surprised. Unfortunately, we do so many things to people that make them die slowly because of a lack of education. We think it's helpful. Oxygen therapy, it's not helpful. So we need to manage the shortness of breath, but that doesn't necessarily mean that we tether someone to oxygen and make them die slowly.
Yeah, that's a great argument about the person that you were talking about, just for hospices to refer early and the benefits of referring early. And it doesn't mean you have days and weeks if you're referred to hospice, that you really can take advantage and benefit from those services much earlier.
Well, sadly, 30% of people in the United States use hospice for less than, 75% of people in the United States use hospice for less than 30 days. Yeah, and that hasn't changed. And there's a huge percentage, I think it's 30%, use it for less than 7 days. So yeah, it's better that it's not this scramble at the end of life to bring in the hospice team. However, I would also say that if you've already had the palliative care team engaged, it's not quite as much of a scramble. And people who end up only being in hospice for a week after a year of palliative care are still benefiting because they've had this type of care model threaded through, and they're supporting them and their families, and they're prepared. And that makes a huge difference.
Absolutely, it makes the transition easier. Thank you, many thank yous in this question box. I have bulbar ALS advanced stages, very focused on fighting each day. How does one know when to inquire about hospice?
So hospice you can inquire about hospice anytime and begin to establish a relationship with a hospice team and even shop around a little bit. Obviously, you'd want to ask your clinicians, who do they recommend? Because there's probably 50 different hospices or more in the Chicago area. And I have about 6 or 8 that I work with, that I trust, that they would even take care of my mom. So you want to get a recommendation from your care team to start. You want to pick the one that you feel the most comfortable with, and you can have them in the wings. You can have a conversation with them months and months and months before they might be somebody that you turn to, but you have then a relationship. So if something happens, a pneumonia, an accident, the team that comes in then is actually somebody you know. And as tender as it is to say, hey, I want you to interview some hospice programs to my patients, more often than not, that ends up being a very empowering experience and very positive experience because they feel in control that these people are going to help take care of me. So I'd say early and see who you meet and see if these are people you feel comfortable with. And then they can integrate into your care and get to know you better until which time they actually are your care team.
That's great advice. Is there a difference between an healthcare power of attorney and a healthcare proxy, or are they the same things, just 2 different ways of describing?
It's same thing. Same thing.
Okay,
That's
what I thought.
Yeah. And they're also called a legal substituted decision maker, an LSDM is another term you'll hear.
Let's see if we have it. Looks like, okay, your slide says that patient's spouse or civil partner is a surrogate. Who qualifies as a civil partner in Illinois?
That's a really good question. I probably have to ask my legal buddies if that's changed. It's typically someone that we're in a sharing relationship with for a period of time, is my understanding. It's almost like common, what do they call them? Common law wife or
Yeah.
common law husband. I think you have to demonstrate that that person has been a part of your life for a significant period of time. It's not that you just met. But there may be more other terms that have developed because, like, I didn't know New Jersey was now legal. Things happen in law that I'm not on the cutting edge of. So I would ask who defines civil partner, and what's better is just create a power of attorney. It is, it could be your best friend, it could be your son, it could be your neighbor. It's just the person who gets you, who champions for you, and who can be your voice. That's who you want to choose, and just put it on a piece of paper and have somebody witness it. That's it.
Yeah. Wow, so helpful, so helpful. Those are all of the questions. I'm sure I will receive more after we end today. Dr. Twaddle, thank you so much. I will be sure to pass on any additional questions that I receive to you. I will share your presentation, and this was just really, really incredible. Thank you so much for this opportunity to have these conversations.
Well, thank you for the opportunity to be with you, to provide this. It is an offering from my heart, and I hope it is helpful. I really do.
Hope to see you again soon, Dr. Twaddle. Bye-bye.
Yes. Yeah. Bye.
All right, we are going to stay on as Dr. Twaddle has completed her presentation. And I would like to invite you to our next webinar next month. Please join us for a presentation from our very own Director of Support Services and Education, Lauren Webb, to learn about a new innovative decision-making tool for people and families impacted by ALS. You will not want to miss this. And I wanted to take a moment again to just thank Dr. Twaddle for sharing her knowledge and expertise with us today. Thank each and every one of you. And we look forward to having you join us next month. But please, before you log off, if you could take just a moment to fill out our survey, because your feedback is important to us. Thank you, and I'll see you again next month.